This is Brent of the Brookbush Institute, and in this video I wanted to show you guys a quick hack for reducing the overhead squat assessment to just upper body signs and perhaps increasing the reliability of our upper body movement assessment. I'm going to have my friend Yvette come out. She's going to help me demonstrate. Now, Yvette's done this assessment before. What we're going to do is start against a wall. So head against the wall, back against the wall, and butt against the wall. Feet just have to be relatively close to the wall. They don't have to be all the way up against the wall. Now, going through my overhead squat assessment signs, I know that if somebody can't keep their arms in line with their body, that would be arms fall and a sign. If we have scapular elevation, that's a sign. An excessive lordosis, increase in lordosis or anterior pelvic tilt, can be an upper body sign because the latissimus dorsi, with their propensity to get overactive, can actually pull on the posterior iliac spine and turn us into an anterior pelvic tilt or increase our lumbar lordosis. And then the last sign we could kind of like relate back to upper body and cervical dysfunction is forward head. So going back through those four signs, forward head, arms, you'll see can't get against the wall, scapular elevation, or excessive lordosis become real easy to see when we put somebody against a nice flat wall that gives us a 180-degree reference. Right? So all I'm going to have Yvette do is, now that she's back against the wall, hey, can you lock your elbows for me? And then I'm going to have you keep your arms right next to your ears, essentially, and go all the way back up to the wall. See if you can get your hands to the back of your hands to the wall. And you can see already that Yvette can't do that. All right, now keep in mind you guys are going to want two views on this. So I'm going to want a lateral view and a front-on view, right? So we both kind of have the lateral view here, guys. And the lateral view, you can tell her arms can't get all the way back to the wall. She's maintained good contact with the back of her head to the wall. All right, and this lordosis didn't seem to increase. We can do this one more time. Right, so you can even put your hand there if you guys want. Just make sure your clients know what you're up to. And her lordosis didn't increase at all. So what I'm thinking from the side view right now is, okay, her arms fell. That's it. Of my four signs, we just have arms fall. Now, I would then go to my front view, ask her to do it again. And from the front view, I might see those elbows bend. I'm going to show you guys this in a second here. And I also noticed that she had some elevation of her scapula, right? Her shoulders kind of crept up this way. So with Yvette, of my four signs being forward head, arms fall, scapular elevation, excessive lordosis, she has arms fall and scapular elevation. I'm going to go ahead and have you face the camera now. So pretend there's a wall behind her. Remember, in this view, what you're really looking at is, do her elbows bend and does she have scapular elevation? All right, go ahead and go up. All right, and you guys can see how like this starts to come up. And she likes to bend her elbows when she gets up there. And of course, that's just a cheat for the lack of flexion in her shoulder complex. So let's try that one more time so they can see. Good. Great. All right. Let's go ahead and have you turn back to the wall. Now you guys can imagine this is a really easy test to do and something I can keep reassessing. And rather doing the whole overhead squat assessment, as you can imagine, if somebody came in with like shoulder impingement syndrome, having them do a squat doesn't necessarily help. Now, some of my movement geeks out there, you might be able to explain to me how an asymmetrical weight shift will contribute to a loss of shoulder flexion and how that can contribute to shoulder impingement syndrome. But from a practical standpoint, if somebody comes in with shoulder impingement syndrome, they have something wrong with their upper body that needs to be treated out first before you go down to this asymmetrical weight shift. Keep that stuff in mind, right? But if I was working with Yvette, she had like shoulder impingement syndrome, I noticed arms fall, well great, now I have a retest to keep coming back to, right? I can do some stuff and go, okay, let's see if that got better, right? So go ahead and do it again. Oh, that didn't get better. Does that happen during treatment? Absolutely. What did I learn? Well, I learned that whatever I just did maybe we don't need to do again because it didn't seem to work out. Of course, if I did something that did work, I could make note and we could keep doing that to keep seeing improvement. Right, so there you guys have it. If you have anybody who has just upper body signs, you want to address just upper body signs, you could, rather than doing the full-on overhead squat assessment, do this upper body only version. Or if you had somebody come in and they had an obvious upper body complaint, cervical pain, like suprascapular complaints, they had shoulder impingement syndrome, right? These are reasons that maybe we don't need the rest of the overhead squat assessment. We can come to this quick assessment that we can do over that might be a little bit more reliable because we have this 180-degree reference behind us. And it just makes everything just that much better for making our assessments a little bit more reliable. If you guys have any questions, please leave them in the bottom.